Thank you. I'd like to thank the organising committee for inviting me to this beautiful city. It's been a fantastic conference so far, and I hope I don't let everyone down with this talk. So what I'm going to do is I'm going to talk about post-transplant glomerulonephritis. Here are my disclosures. So recurrent glomerulonephritis and de novo glomerulonephritis are common problems post-transplantation. And I'm sure for all those transplant nephrologists in the room, this is something that you see in your day-to-day practice. It's common because glomerulonephritis is the third most common cause of kidney failure worldwide. And so these are the patients that are going to present to you needing a kidney transplant. And virtually every glomerular disease may recur post-transplant. We need to remember, of course, that many of our GN patients have been exposed to significant immunosuppression pre-transplantation, and therefore they come to you at a time when they get their kidney transplant with a cumulatively higher risk of infection and malignancy because of the immunosuppression they've already been exposed to. And that's compounded if we want to immunosuppress them further, in addition to their anti-rejection treatment, if they develop recurrent disease. It's estimated that up to 1 in 5 patients with GN will develop recurrence post-transplant. And of those that develop a recurrence, 50% will lose their graft on long-term follow-up. And the majority of these recurrences occur within the first 3 to 5 years after transplantation. I'm sure I don't need to tell people in the room, but recurrent glomerular disease is the third most commonest cause of graft loss 10 years post-transplant. So it has a significant impact on kidney transplant outcomes, particularly over the longer term. I think we do need to get our terminology right, where we talk about recurrent and de novo glomerular disease. So if we talk about true recurrence, this is the situation where we have a diagnosis in the native kidney by kidney biopsy, and we have the same diagnosis showing recurrence in the transplant biopsy. That is something we see regularly, but perhaps more commonly, we have a situation where we diagnose a glomerular disease in the transplant kidney, but we didn't know the cause of the kidney failure in the native kidneys because these patients are presented late, often with small kidneys, which cannot be biopsied, and there's been a presumptive diagnosis of chronic glomerulonephritis or hypertensive nephrosclerosis. And here, it's difficult to say whether this is de novo disease or whether this is true recurrence. And then finally, we have those, I think, rare instances where we knew the diagnosis in the transplant kidney, in the native kidneys, and then we make a diagnosis of a new glomerular disease in the transplant kidney. And perhaps the best example of this is in patients with Alport's disease who are transplanted and then develop de novo glomerular basement membrane disease. So what are the diseases I'm talking about? Well, we've got the range of primary glomerular diseases. We've got secondary glomerular diseases associated with systemic conditions. And then we have systemic diseases with glomerular involvement. Those diseases that are described as occurring de novo, most commonly are FSGS, IgA nephropathy, membranous, membranoproliferative, and anti-GBM disease. And I'll discuss those a little, but I'm going to focus on true recurrent disease. And so which are the ones we need to watch out for? Well, these are the 4 most common diseases that recur post-transplant: IgA, FSGS, membranous, and MPGN. And you can see across the bottom the likelihood of you losing your graft with these recurrent diseases. And we're much more likely to use your graft with C3 glomerulopathy. You're least likely to use your graft with recurrent lupus or if you have lupus, ANCA-associated vascular anti-GBM. That's because we know how to get the patient ready for a kidney transplant, so we avoid that risk of recurrence. And then you've got this mixed group of diseases in the middle where there is a reasonable likelihood that there will be significant graft function, even graft dysfunction or even graft loss with recurrence in the transplant. The most important thing I want people to take away from this talk today is when you're faced with a patient who has graft dysfunction, blood and protein in the urine, ask yourself, why is this not recurrent or de novo glomerular disease? There are lots of reasons why you can get graft dysfunction, and recurrent disease is often one of those that's at the very bottom of the list. And the reason I say that is because really the only way we can diagnose recurrent glomerular disease is with an appropriate kidney biopsy. And when I say appropriate, it's a kidney biopsy performed in the same way as we would do for a native kidney, where we collect samples for light, for immunofluorescence, and if we have it available, electron microscopy. Certainly in Leicester, we're faced many times with thinking there's a recurrent disease, but the person who's taken the transplant has just taken a sample for light. And we cannot exclude or confirm recurrent GN because we don't have the right kidney biopsy samples collected in the right way. So when you see someone with graft dysfunction, ask yourself, why is this not recurrent disease? And if you think that's likely, and you're going to do an allograft biopsy, make sure you collect the samples as if you're doing a native kidney biopsy to give you the best chance of identifying recurrent glomerular disease. In terms of presentation, it's the same as native disease, blood and protein in the urine, impaired kidney function, possibly even development of nephrotic syndrome. General treatment is the same for any general proteinuric disease, and we're sadly lacking in most situations for any specific disease in the recurrent disease because we really don't have great treatments for the primary disease. So what I'm going to do over the next few minutes is I'm not going to talk about C3 glomerulopathy because I've got a talk tomorrow about transplantation in the setting of complement-mediated kidney diseases, so I'll focus very much on those two diseases tomorrow. What I am going to do is focus on these primary glomerular diseases and transplantation in the setting of secondary glomerular diseases. So if we think first about IgA nephropathy, I wish I could talk to you about IgA vasculitis, but there's virtually nothing in the literature talking about IgA vasculitis. So I'm going to focus on IgA nephropathy. So how common is this? Well, this is some information, this is some data we've recently published from the UK Rare Disease Registry called RaDaR. And this shows the outcomes in over 4,000 UK adults and children with IgA nephropathy. And what you can see here is that the 20-year survival for someone in the UK living with diagnosed with IgA nephropathy is that 75% of adults will have developed kidney failure at 20 years after diagnosis, and 50% of children. These will still be young people. If you look here by age at biopsy, you can see here, if you're diagnosed as a child, by the time you get to my age, which is that red arrow, 55, over 3/4 of children have developed kidney failure. If you look between 18 and 40, 2/3 have developed kidney failure. And if you look at those diagnosed between the ages of 40 and 50, half have developed kidney failure. So these are absolutely the type of people you are going to see coming along to be assessed for kidney transplant and potentially looking after once they've received their kidney transplant, because this is a disease of young people, and it puts people on dialysis at a young age, when they usually only have single organ disease, and they're fit, and transplantation is the ideal treatment for their kidney failure. There's some very nice data from Cecina Alexander from Vellore, the cohort that she's collected in India. The outcomes are even worse in India. So this is absolutely a disease, and I'm sure we'll have some conversation at the end that you are going to look at patients you are going to look after in your clinical practice who suffer with end-stage kidney disease at a young age and are transplanted are at risk of recurrent disease. It gets very confusing when you look at how common is recurrent disease, because you need to be really careful what you're talking about. Recurrence of mesangial IgA deposition is very, very common. And the later you biopsy after a transplant, the more likely you are to see it. The key thing here is, though, is that recurrent mesangial IgA causing glomerular inflammation? And that's where you need a very good pathologist like Mark to be able to tell you, Is this recurrent IgA causing graft dysfunction? Is it just sat there? Is it transplant glomerulopathy? Is it CNI toxicity? What is the cause of the graft dysfunction? Because it can be very difficult to tease out what is due to recurrent IgA nephropathy and nephritis, and what is due to all the other things we see in transplantation. And Mark is leading a group from the International IgA Nephropathy Network to try and understand how we better define recurrent IgA nephropathy when we may want to treat that specifically. So you'll need to watch this space to hear more about that. But we know outcomes are good, at least in the short term in IgA nephropathy, and you can see here some data from a little while ago. In the first 5 years, you can see IgA nephropathy patients in the yellow do better than the controls. They're young, they're fit, they're single organ disease, they tolerate the procedure well. But you can see after 5 years, the recurrence starts making an impact, and the outcomes became less good over the longer term. And that's the typical picture we see in IgA nephropathy cohorts post-transplantation. So what's the natural history? Well, we know you see mesangial deposition. There may be no glomerular consequence to that, but then you start the appearance of non-visible hematuria, proteinuria, progressive allograft dysfunction, and then allograft failure. And you can see that develop real time if you look at your patients with IgA nephropathy, particularly if you do protocol biopsies. But the only way you can diagnose recurrent IgA, in the same way as the only way you can diagnose IgA in the native kidneys, is with a kidney biopsy, appropriately collected and stained for IgA, along with electron microscopy if you have it available. So what are the risk factors for recurrent disease? Well, really the risk factors are related to how aggressive the disease was in the native kidneys. So if you're a younger age at transplant, you've had worse disease, rapidity of progression in the native kidneys, and the fact you've had a previous recurrence all indicate you have active IgA disease, you're at increased risk of recurrent disease. We know about the pathogenesis. It's an immune complex-driven disease driven by Gd-IgA1 that promotes immune complexes, and there are autoantibodies. Unfortunately, measuring any of these does not help you predict who is going to recur, and they don't help you monitor post-transplant. We're desperately in need of good biomarkers. Studies have suggested ATG induction is associated with a lower risk, steroid-free or withdrawal regimes are associated with a greater risk, and zero HLA mismatched kidneys are associated with a lower risk. These are population observations. I'm not sure that they should inform your particular use and management of patients, but this is what the literature tells us. How do you treat this disease? You give good supportive care, and in a perfect world, we enroll people into clinical trials. But we don't have any clinical trials at the moment, although we're desperately trying to set those up. We have lots of new therapies for IgA nephropathy in native kidneys, and the hope is these will translate through to recurrent disease. So what do I do in Leicester? Well, at the moment, in patients who've already lost one graft from recurrent IgA nephropathy, what I do is institute protocol biopsies every 4 months post-transplant. When the patient gets down to between 5 and 10 milligrams of prednisolone, I convert to a mucosally directed steroid to give the similar systemic absorption but to target the mucosal production of IgA. And if their kidney biopsy shows inflammation associated with IgA position, I'm using complement inhibitors on a compassionate basis. And then hopefully we'll have access to BAFF and APRIL inhibitors in the full time. But this is all done not in the context of a clinical trial, but pragmatically in those who've already lost a single graft to recurrent disease. What about FSGS? Well, I think we need to be cautious about FSGS because it's a pattern of disease. We have that disease that is associated with a soluble mediator, a permeability factor. That's the one we worry about recurring. Genetic FSGS generally doesn't recur in the kidney transplant because you're putting in a kidney with normal genomics. And then those secondary forms of FSGS, normally if we've dealt with the precipitant, then actually this disease does not recur. Although actually when we see FSGS in a graft, it's probably related to the same maladaptive responses that we see in native kidneys. We know again that primary FSGS is a disease of young people. It has a high risk of causing kidney failure. So these are the patients you are going to see in your practice. And we know that the more aggressive the disease, the earlier the patients develop kidney failure, the more likely they are to develop recurrent disease. It's really difficult to gauge incidence. It's suggested that if you have primary soluble mediator factor related FSGS, recurrence can occur in up to 50% of patients. And if you get recurrence, graft loss occurs in roughly a third to a quarter of those patients. Recurrence can be early. It can be within 48 to 72 hours post-transplant, or it can occur later over months to years, usually with the presentation of nephrotic syndrome. If you biopsy early, you're not likely to see segmental sclerosing lesions because they haven't had time to develop. This is where electron microscopy is critical, that you can see the foot process effacements. If you biopsy late, there's been time for the scars to form, and then you will make a clear diagnosis of recurrent FSGS. In terms of risk factors of recurrence, again, like IgA nephropathy, they are the risk factors associated with aggressive primary disease. So if you've developed kidney failure as a child, younger age of transplantation, rapidity of progression in the native kidneys, steroid resistance, and previous recurrence are all high risk factors for recurrent disease, along with non-white ethnicity. We're beginning to understand more about the pathogenesis of the disease, but unfortunately those key factors we still don't know. What is the permeability factor? What is the defect in the immune system? And therefore, we have no biomarkers to be able to help decide who is going to relapse and who isn't. And we don't have biomarkers that allow us to monitor response to therapy, unfortunately. There is an increased risk of recurrence with live donor transplantation from population studies, and really no evidence that any particular induction or immunosuppressive regime is better or worse in this disease. In terms of treatment, to be honest, lots of things have been tried. There is no consistent benefit shown from any of these approaches, but they're approaches that we do use when we have a patient with recurrent primary FSGS. We can use plasmapheresis, immunoabsorption, or we can use immunosuppressors, rituximab, abatacept, infliximab, etanercept. These are all tried. We've tried these in our own unit to variable success. But quite frankly, there really is no tried and trusted protocol as to how to manage this disease when it recurs in the transplant. If we think about membranous, there's few data. In the pre-rituximab and PLA2R era, recurrence rates were said to be around 40%, with 50% graft loss at 10 years in those who do recur. And really, there was very little understood about risk factors for recurrence, and optimal treatment was not known. But now we know about PLA2R. We know that actually if you are, PLA2R should be suppressed pre-transplant, that rising PLA2R levels are associated with a higher risk of recurrence, and that we would potentially use rituximab to treat this just like we do in native kidneys. There's a lot of debate about whether you should use preemptive use of rituximab in these patients, particularly in those who've already lost a graft and have high PLA2R levels, or where you see persistent high PLA2R levels with early histological change. Limited small case series, but I think this is something you need to look at on a case-by-case basis between the transplant nephrologist and your local GN experts. In terms of those secondary GNs, this is where we have made headway. If we get the patient at the right clinical state before transplantation, recurrence risks are low and outcomes are good. So we should not be transplanting a patient with ANCA-associated vasculitis for at least 12 months after clinical remission has been achieved. ANCA positivity is not a contraindication, but PR3 positivity is something we take very seriously and monitor very closely. You can see recurrence does occur, but actually outcomes are good because we have good treatments for the underlying disease. In terms of lupus, again, recurrences can occur, but we would not be transplanting someone with obvious active disease, and we have treatments for lupus, and so we can use those in the setting of recurrent disease in transplantation. And you can see those risk factors here for recurrent disease on the screen. In terms of anti-GBM disease, again, we do not transplant patients until they've been antibody negative for at least 12 months. We know if we do transplant patients and they're antibody positive, there is a high risk of recurrence and a very high risk of graft loss. And don't forget the risk of anti-GBM disease in the setting of Alport's disease. So as I come back, if you take anything from this talk, it's when you're looking at a patient with graft dysfunction, ask your question, why could this not be recurrent or de novo glomerular disease. And if that is a possibility, make sure you take the right biopsy, because that's the only way you're going to be able to know for sure. We're sadly lacking in data, but there is a global study consortium that is looking at this, and if you're interested, it's worth having a look at this website. It's called the TANGO study. It's a large registry of patients with post-transplant glomerulonephritis, where there are biorepositories and clinical outcome data. So I'm going to finish there, and I'd like to thank you for your attention.
Thank you, sir, for the lucid presentation. As we are running short of time, we can take only just one question, ma'am.
Yeah, a clinical puzzle that puzzles us often. We, I think, do a lot of IgA in transplant, and they do recur. So if I get a patient of subnephrotic proteinuria, post 5 year, no history of acute ABM or ALIR, no 4D signature, C4D signature on IF, so that I can contribute it to proteinuria to TG or something. So IgA recurrence, minimal TG, if to 30%. Do I go for a steroid hike?
So this is a patient where you have biopsy-proven recurrent IgA?
Yeah.
And there's no other indication of transplant glomerulopathy or...
Yeah.
So in that situation, what we would do is maximize supportive care.
Yeah, on top of maximized ARB and blood pressure control up to the level of 120/80. That we will do always. And on top of that, do you think any steroid high could work?
So the first thing to say is the patients I look after are very different to patients in India and patients in other parts of Asia. And we know that patients are responding differently to treatment. So my experience in a Caucasian population may not be relevant to yours. So one of the things we've done, had a lot of discussion about, is whether actually in that situation, a gut-directed steroid, we have Nefecon, but I know there is a variety of different gut-directed steroids here. I would not give that patient high-dose systemic corticosteroids. I would look very closely at the biopsy. If the biopsy showed lots of glomerular inflammation, then I would be thinking about what treatment that might need. But if this is someone with proteinuria, perhaps a little bit of mesangial cell proliferation, IgA deposition, I would be going for a gut-directed steroid in that situation as an additional therapy on top of a RAS inhibitor, an SGLT2 inhibitor, and potentially a mineralocorticoid receptor antagonist.
Both the SGLT2I and Nefecon, I do not know whether you have used Nefecon in post-transplant. In post-transplant, evidence of both is awaited. We do not have any robust work on that. The post-transplant is SGLT2I and post-transplant IgA with Nefecon. So do you use Nefecon in post-transplant IgA recurrence?
So we are doing it in those who've already lost one graft. And we're doing that at the time that we reduce the steroid dose to between 5 and 10 milligrams, because we know that patient is at high risk. What we don't know is the safety profile of Nefecon in the context of taking that with tacrolimus and MMF.
Yes,
that we don't know. So that's the worry. That's why we're only doing it in the really high-risk people that have already lost a kidney, because we think the risk-to-benefit ratio is appropriate there. I think over time, we are likely to see this move to those people who've had a rapid disease in their native kidneys and are going to be transplanted, because they're at high risk of early recurrence. But at the moment, we're just really early in doing this, so it's really on a patient-by-patient basis. And I use complement inhibitors because I can access those on a compassionate use for those patients who have
using a lot of MAPs.
Yeah, because they to deal with those that have very high levels of inflammation in recurrence. And
if it is very high M1 and
endocapillary hypercellularity, if there are crescents, there's lots of inflammation, I will use a complement inhibitor as an anti-inflammatory.
Yeah. We don't have exact Nefecon molecule in India, but we have a budesonide preparation that we are using, and I have done a trial with good response, relatively good response.
So I think India is a great place. I'm a big advocate for clinical trials. So if you could do a clinical trial in India with the mucosal directed steroids you have available, that would be fantastic to be able to look at that, to look for safety and to look to see how well it works. And the beauty, of course, is the kidney can be biopsied. You start the drug, you look 12 months later, you can see whether you've impacted on that IgA deposition and the inflammation.
We showcased it in WC and we will come out with.
Thank you.
With that, we would now like to felicitate sir. Can I request Dr. Pratik Das sir to please join us on the stage? And we would like to thank the chairpersons and